The next session is on pulmonary rehabilitation, and may I kindly invite Dr. Manomohan Biswas and Dr. Dibyendu Das, consultant physiatrist, to the dais please for taking over the proceedings. The esteemed speakers would be Dr. Chayan Chakraborty, Associate Consultant, Department of Pulmonology, Apollo Multispeciality Hospital, Kolkata. Dr. Chakraborty, if you can kindly come up on the dais. And following him would be Dr. Shagnik Mukherjee, who shall be speaking on the rehab aspect of COPD, followed by a flash talk on the rehabilitation of interstitial lung diseases.
Good morning, everyone. So, first of all, thank you. I thank all the organizing members to having me here, because it is always a pleasure to learn from the other specialty for us, and we don't get much of chance to go to the other specialty conference. And in the next 15 to 20 minutes, I'll be talking about the management of COPD, especially the exacerbation part, and followed by the how we will follow up in the OPD. So, few days back on the 19th November, it was World COPD Day. And every year on this very day, we get a guideline from the global initiative, which is called Gold Guideline. And every time they come up with something new on the diagnosis and the management part. This year, we got two new updates. So, first update is on the burden of COPD. Burden of COPD is increasing as we every time see that African continental countries are more affected. And this year they have gave one new thing that female number of COPD patients are gradually increasing. And what about in our country? Our country, the prevalence is still the same, almost 7.5%, 11% in the urban areas, 5.6% in the rural areas. But in this context, we have to remember that in our country, 65% of the population lives in rural area. And as like all the low and middle income countries, the young COPD patient, number of young COPD patient is more in our country also. Now, if you see the map, the northern India are more affected. There is more prevalence of COPD. But in this pessimistic era, where is the hope? In this 2025 February, there was one heat map analysis, AI-based heat map analysis was published, which have shown that by 2031 there will be decrease in the number, significant decrease in the number of COPD patient in two states in India. That is, first one is Rajasthan and second one is Uttarakhand. So hopefully in West Bengal also we'll see some era of hope. Now, second thing they have emphasized that why we diagnose the COPD when it is far advanced. So they have shown three things. One is patient related factors, another is healthcare system related factor, like spirometry, which is an essential tool to diagnose COPD. It is not available everywhere, especially in the periphery. And healthcare provider related factor. We sometimes keep our threshold very high up to diagnose COPD. So to diagnose early, we have to keep our threshold low, because there are so many risk factors. Healthy aging is not happening everywhere. There are symptoms coinciding with other diseases. So if you keep the diagnosis threshold a little bit low, we can diagnose the COPD early. Now, the most important part is patient related factor. So what are they saying? That milder disease or milder impairment is most of the time remain undiagnosed, and patient adapt their lifestyle, adapt their daily activity with that minimized breathlessness. Sometimes they just shrug their shoulder to decrease the dyspnea, and the under recognition or under reporting of the symptoms sometimes become the main issue. So to begin with, how do you encounter a case of exacerbation of COPD? So whenever a patient comes to you with increased breathlessness, you have to give a thorough examination, and you have to keep in your mind that every time they do not come with COPD exacerbation, they can come with myocardial infarction, minor coronary artery disease, simple pneumonia, and other disease like pneumothorax, pulmonary embolism. So almost there is a 6 to 8% chance every time the COPD patient comes to the emergency with pneumothorax, pulmonary embolism, cardiac morbidity. And then you have to grade the severity of their symptoms. Okay, and you have to look for what is the heart rate, what is the saturation at room air, or what is the whether there is tachypnea, tachycardia, how much they are producing the sputum, etc. And after that, you have to evaluate that what is triggering their exacerbation, whether there is a recent reduction in FEV1, or whether there is a under treatment going on. After that, you classify the severity based on these 5 or 6 parameters. The respiratory rate, the cutoff is 24 per minute, heart rate, resting saturation at ambient air, and if blood investigation is available, CRP, the cutoff is 10, and if ABG is available, you grade the severity in mild, moderate or severe. After that, you have to plan the management, whether you will send the patient home or whether you will ask him to get hospitalized. If it is a mild exacerbation, all the comorbidities are well managed, then you send him home and give some medications. And if the patient's symptom is more and there is hypercarbia, the ABG is not good, showing acidosis, you have to hospitalize the patient. Even the other comorbidities, like if there is heart failure or some ongoing arrhythmia, then also you have to ask the patient to hospitalized. Now, there are some indications like ABG is not improving, worsening mental status, very important, whether they are going to coma or lethargy. Those are even hemodynamic instability, you have to ask the patient to get hospitalized to medical ICU. Now, after you decide the plan of management, you have few things in your armamentarium. First is pharmacological. In the pharmacology part, the most important is bronchodilators. So what we suggest that whatever patient is using, if it is a short acting bronchodilators, we just increase the frequency of the ongoing bronchodilators. And if the patient is getting hospitalized, then you just increase the nebulized dose. And after that, systemic corticosteroid. You have to remember one thing, that IV corticosteroid or oral corticosteroid both have similar efficacy in managing exacerbation, and whether it comes into the antibiotic group. So if the patient is getting admitted in medical ICU, then you have to give antibiotic. And if you are sending the patient home, whether they are producing more purulent sputum, and if there is history of previous hospitalization, you have to give antibiotics. And the course will be minimized. Course can be minimized in between 5 to 7 days, but not more than that. Then comes the most important part, the managing the respiratory failure part. So few patient gets managed by simple long-term oxygen therapy, but if it is not getting managed, then we have high flow nasal oxygenation. So HFNO got very popularized after COVID, but still now in the guideline it was not coming. Since last 2-3 years they are recommending high flow nasal oxygenation in place of NIV. So when we prefer this, if there is persistent hypoxemia, if there is contraindication of NIV, and if you are just trying to delay the intubation, the mechanical ventilation, then you can prefer this high flow nasal oxygenation. What is the benefit over simple oxygen or nasal cannula? That it provides some PEEP or positive end expiratory pressure, which nasal cannula cannot provide. But if there is respiratory acidosis, patient's work of breathing is high, like patient is using respiratory accessory muscles, paradoxical motion of the abdomen is happening, there is retraction of the intercostal space, persistent hypoxemia, you have to prefer non-invasive mechanical ventilation. But if it is not controlled and patient is hemodynamically unstable, there is some ongoing supraventricular or ventricular arrhythmia, patient is not able to tolerate NIV or HFNO, then you put the patient on mechanical ventilator. So these are the part of the initial management, and we expect the patient gets stabilized. But whenever you discharge the patient, you have to keep in your mind these things. So all the lab whatever you have done, you have to review before you discharge the patient. You have to provide the patient a proper management plan. you have to ensure that you have given steroid, you have given antibiotics to the patient, and you are withdrawing whenever you are discharging the patient. So there can be some effect during withdrawal of these acute medications, and you have to ensure that patient know the inhaler technique very properly and check the maintenance therapy. Now you ask the patient to come for follow-up after 1 to 4 weeks. Then you have to again reassure that whether the patient needs the long-term oxygen therapy. Inhaler techniques you have to cross-check, and you have to document the symptoms through few assessment score like CAT score or MMRC score. Next visit will be after 3 months, 3 to 4 months. And next visit you check all the things like physical activity, how the patient's mobility is increasing or not, how the comorbidities are getting controlled. One extra things you have to check, that is FEV1, or you have to do one spirometry. Now these are the drugs. So in the drugs we have beta agonist, whether it is SABA or LABA like formoterol, anticholinergic SAMA like ipratropium, LAMA we have glycopyrronium, tiotropium. There are some combination therapy, SABA plus SAMA, LABA plus LAMA, LABA plus ICS, and nowadays we are dealing with LABA, LAMA plus ICS. Those are most of the time it is MDI or DPI format. I think by next week we will be having the this budesonide, formoterol and glycopyrronium in nebulized form also. So, and in for controlling the exacerbation we have biologicals, mucolytic agents and phosphodiesterase 3 inhibitors. Now these bronchodilators, there are previously we used to use LAMA, a very common medication. The UPLIFT trial has shown that there is no reduction in mortality. Followed by LABA ICS came up and they showed that TORCH and SUMMIT trial there was no reduction in mortality. Now currently in last 5 years IMPACT and ETHOS trial has shown LABA, LAMA plus ICS. This triple therapy combination has shown all cause mortality benefit over dual inhaled long acting bronchodilator therapy. Now how the treatment has evolved in the on the OPD basis. In GOLD 2016, if we see that on the x-axis there is dyspnea scoring, and in the y-axis it is how the patient is frequent exacerbator or not. So we divided the group A, B, C, D in GOLD 2016, and we decided the treatment SAMA or SABA for group A, LAMA or LABA for group B, group C, ICS plus LABA, and group D we will consider adding ICS LABA plus minus LAMA. 2017 they changed that group C LAMA only therapy, LABA plus LAMA for group D therapy. 2019 the change again came back to the 2016, like LAMA plus minus LABA we will use for group D. But in the 2023 they have merged the group C and group D and name it as group E. E for we can call it exacerbation. So why they did it? Like if you think that a patient who has more dyspnea but he is not experiencing exacerbation, that group of patient is very less in number. Almost we don't see in our practice. So that is why they merged these two groups and they decided to give these group LAMA plus LABA. So what we have seen in the last trial. So what is the current recommendation? GOLD 2026 is recommending group A, B and E. There are 3 groups, and for these 3 groups, for group A you can prefer any bronchodilator, whether it is LAMA, whether it is LABA, any bronchodilator will be enough. For group B, LABA plus LAMA, and for group E, if the patient's absolute eosinophil count is raised, then you can consider adding ICS. So this is about initial therapy. So dual bronchodilator therapy is the official new gold standard. What next? But patient again comes to you, they are complaining that yes, I have dyspnea. Then you have to consider other pharmacological therapies, other non-pharmacological options. And if they complain of exacerbation more and more, then you have options like adding inhaled corticosteroid, adding roflumilast, adding long-term azithromycin for 3 months or 12 months. Or we have recently in our hand biological therapy like mepolizumab and dupilumab. Now there is always a controversy, inhaled corticosteroid I will give, the patient will come to me with pneumonia. So that is why GOLD has strong recommendation that if the patient is exacerbating more, likely more than 2 per years in last 12 months, and there is blood eosinophilia more than equal to 300 absolute eosinophil count, history of concomitant asthma, history of recent hospitalization, then you have to add inhaled corticosteroid. But yes, if there is history of recent mycobacterial disease or tuberculosis, blood eosinophil count less than 100 and repeated pneumonia event, then prefer to avoid inhaled corticosteroid. Now let's recapitulate why we treat COPD. There are 3 targets. We have to minimize the disease activity, we have to prevent the disease progression, and we have to reduce the disease impact. But despite doing everything, almost 40% of the patient on pharmacotherapy, they used to suffer from high symptom burden. So what options more we have? We have to vaccinate every patient of COPD, like influenza vaccine, pneumonia vaccine, RSV vaccine we have. Next, we have to keep our patient physically active. Like last year, one trial has come up. They have shown that every COPD patient, however sedentary they are, if it is a female, 4,200 steps per day is a must, and 4,400 steps per day is a must for a male patient. Okay, and what is must other than these pharmacotherapy? That is number 1, smoking cessation. Second is pulmonary rehabilitation. So I am not the person to talk about pulmonary rehabilitation. The Dr. Shagni Mukherjee will talk about that. But this is a very favorite slide, that if you start from the stair climbing, and if you go up to the high intensity continuous cycling, every time the physical activity or exercise capacity of COPD patient, whether you start early, whether you start late, every time the exercise capacity will anyway improve. And they have WHO has come up with WHO 2030 initiative for the low and middle income low and middle income countries. So they are trying to culturally encroach through culturally adapted approaches. This is a picture from Kyrgyzstan. So almost every patient of COPD, they are going to the proper hospitalized peer program, and they are targeting that almost all the Asian countries will be encounter this 2030 initiatives. So what we have to keep in our mind, we have to revise, de-escalate, escalate medications in every visit of COPD patient. We have to check that whether the patient is going to depression, whether there is any kind of cognitive impairment or not. We have to take care of all the comorbidities, especially the cardiac comorbidities and mobility. Every time we have to try to increase the exercise capacity of the patient. So what is the take-home message? COPD is not a lung disorder, it is a multi-morbidity disorder. So we have to, whenever the patient comes with exacerbation, we have to keep in our mind it can be MI, it can be COPD exacerbation, it can be pulmonary embolism. And we have to increase the interval between 2 OPD visit or 2 hospital admissions. So choose your drug wisely. Every time the patient visit to you, check the inhaler techniques and ask your patient to get involved to a proper hospitalized or home-based pulmonary rehabilitation program. Thank you.
Thank you, Dr. Chakraborty, for the lucid presentation. And now the house is open for question. We can take only 1 and 2 questions. If there is question, please. So, one question.
Yes, sir. Yes, sir.
In case of, say, restrictive pulmonary disease and say, obstructive pulmonary disease, how you will see diagnose clinically?
Okay. So, first one is for obstructive disease, if we use our stethoscope, most of the time during exacerbation, they show rhonchi or wheeze. And for restrictive disease, which is very common in our practice, that is interstitial lung disease or ILD. So ILD has a very typical adventitious sound that we call Velcro crepes. That means late inspiratory and early expiratory fine crepitations. So that can be one differentiating point in terms of ILD. But yes, other restrictive disorder like neuromuscular disorder or chest wall disorder, that is difficult to differentiate in through clinical examinations.
Thank you. Treatment procedure is same.
Treatment procedures are we measure through spirometry, diffusion capacity of lung, and most of the time restrictive disorder, when they come to us with dyspnea, they develop some kind of pulmonary hypertension. Okay, so pulmonary rehab is one resort. Treatment wise it is not same. Treatment of ILD, treatment of obstructive airway disease is completely different.
Thank you very much.
Thank you.
Next speaker, Dr. Shagni Mukherjee, consultant physiatrist, Ruby General Hospital, Kolkata.
Good afternoon, good morning rather, sorry, to our delegates and our respected chairpersons. I'll be discussing on pulmonary rehabilitation in COPD, a multidisciplinary approach for the optimal outcomes. So first we'll just go through a brief overview of COPD. Dr. Choyan has already described this. COPD is the fourth leading cause of death worldwide, causing 3.5 million deaths in 2021, approximately 5% of all global deaths. 90% of the COPD deaths in those under 70 years of age occur in the low and middle income countries. COPD is the 8th leading cause of poor health worldwide, which is measured by the disability adjusted life years. And tobacco smoking accounts for over 70% of COPD cases in high income countries. In low to middle income countries, tobacco smoking accounts for 30 to 40% of COPD cases. And most importantly, household air pollution, cooking and the like, etc. is also a major risk factor. So what happens is there's a downward spiral in COPD, starting from airflow limitation, moving on to hyperinflation, dyspnea, inactivity, poor quality of life, deconditioning, muscle impairment, which leads to weight loss, isolation, depression, severe dyspnea, hypoxia and mortality follow in these patients. So the inflammation, cachexia, the malnutrition, the atrophy of the muscles and the decreased capillarization with a decreased oxidative metabolic capacity, these lead to skeletal muscle dysfunction, a respiratory muscle weakness and a gas exchange limitation. All of these leads to a decreased exercise tolerance, which in turn cause anxiety and depression, finally moving on to inactivity. This is the pathophysiology of disability. And as physiatrists, we are specialists of disability and removing disability as much as possible. So what we do is we move on to pulmonary rehabilitation. What is pulmonary rehabilitation? It's a comprehensive intervention based on a thorough patient assessment followed by patient-tailored therapies that include but are not limited to exercise training, education, behavioral change, designed to improve the physical and psychological condition of the people with chronic respiratory disease and to promote the long-term adherence to health-enhancing behaviors. Goals: to reduce hospital admissions and exacerbations of symptoms, to improve the exercise tolerance and daily activity performance, to increase the muscle strength and endurance, to improve health-related quality of life, to enhance the emotional well-being and promoting self-management and adherence to treatment. So, the team members, a physiatrist, the program leader for the rehab prescription and supervision, a pulmonologist for medical optimization of the treatment protocol, physiotherapists for the execution of exercise prescription and supervision, nurses for the education of the patients and symptom monitorings, dietitian for nutritional assessment and counseling, a psychologist for the support of the mental health of the patient, occupational therapist for ADL training and energy conservation, and a social worker for resource and community support. So these are the components of pulmonary rehabilitation. The first component is a patient evaluation, which includes history, medical evaluation, diagnostic testing, psychosocial assessment and goal setting. So what is the program content of the PR? The education and self-management of the patient, exercises training, nutritional support, psychological and behavioral interventions, smoking cessation, and most importantly, the optimization of the pharmacotherapy. We all know the patient evaluation. Most important part is the history taking, which involves reviewing the detailed history of the patient, identifying other comorbidities which affect rehab, and identifying the barriers to rehab, which may be psychological, social, or logistic. The assessment of the severity of the lung disease and other comorbidities is an important part of the medical evaluation. We monitor the vital signs, breathing patterns, the pattern of use of accessory muscles, examination of the chest, signs like clubbing, oxygen saturation, and evaluation of the strength of the upper and lower extremities. These are the parts of diagnostic testing. Some of these have already been covered by my previous speaker, the PFTs, X-rays and HRCTs, and the 6-minute walk distance. A very important part which is often overlooked in our day-to-day practice is the psychosocial assessment to identify and address the issues which affect rehabilitation like depression, anxiety, substance abuse, sexual dysfunction, social isolation, family and the caregiver support, and logistic issues like transport and finances. So we set goals. What are the specific goals set to with regards to the patient's disease and severity, the patient's needs, expectations, and these are measured by the standardized outcome measures of exercise tolerance, symptoms, and health status. Family members must be included in the process to understand what can and cannot be achieved. We can't expect a patient of a 75-year-old patient who has smoked for the last 50 years to suddenly be able to go and climb Mount Everest after a PR program. Education and self-management. The patient has to understand the disease and recognize the symptoms. He has to be educated about the proper inhaler techniques and adherence to medication. He has to be taught about the breathing strategies, the bronchial hygiene, energy conservation and relaxation techniques, how to avoid the irritants, and we have to provide the patients with proper action plans to manage exacerbations. So these are some of the positions in which the patient can manage exacerbations to ease the breathlessness: high side lying, leaning forward sitting, leaning forward standing, or standing with back support. These are useful in emergency situations. We'll move on to the most central part of PR, the exercise training. The duration of ideal programs is around 6 to 12 weeks, which includes 2 to 3 sessions per week. This improves the exercise capacity, reduces dyspnea, and enhances the quality of life. The exercises are, they may be endurance or aerobic exercises like walking, cycling, and stair climbing, and strength or resistive exercises like inspiratory muscle training and the resistive exercises of the limbs. Inspiratory muscle training increases the muscle strength, increases endurance, and reduces dyspnea. It is of two types, the resistive and the threshold IMTs. In resistive types, the patient breathes through a handheld device in which the resistance to the flow can be increased gradually. And in threshold IMT, patient breathes through a device which is equipped with a valve which opens at a predetermined pressure. So what are the safety precautions which needs to be maintained during exercises? Patient needs to exercise under supervision with someone if the patient has difficulty with mobility before going to the hospital, has history of falls before going or during staying in the hospital, any other health condition or injury like maybe cardiac conditions which may put the patient at risk with exercising, and if the patient was discharged from hospital with a medical prescription of oxygen. Rules. These are the basic rules for the exercises. Always warm up before exercise and cool down after the exercise. Patient should wear loose, comfortable clothing and supporting shoes. Patient should wait at least an hour after a meal before starting exercise, to drink plenty of water, to avoid exercising in very hot weather, and to exercise indoors during cold. Precautions. The patient should not exercise, or if he or she is already exercising, they should stop exercising if the patient is feeling nauseated or feeling sick, dizzy, there's a severe shortness of breath, there's a clamminess or sweating in the extremities, a chest tightness or increased pain. At the right level, if a patient can speak a whole sentence without stopping, then the patient should can exercise harder. If the patient cannot speak at all, then the patient is exercising too hard. At the right level, a patient can speak a sentence, pausing once or twice to catch the breath. Moderately to almost severe breathlessness should not be done. In order to improve the fitness, one should feel moderately to almost severe breathless when exercising. If too breathless to speak, the patient should slow down and stop to rest. These are the breathing retraining techniques which should be taught to every patient with COPD, like pursed lip breathing and diaphragmatic breathing. For mild lung diseases, patient should having symptoms with extreme efforts, the spirometry, ABG are done, and then the exercise is prescribed. For patients with moderate lung disease, exercises should start at a low metabolic equivalent and progress 0.5 METs with each step. For severe lung disease, at low to intermittent level, test exercises set at a steady endurance test of 2 to 3 METs. The duration may be increased to 20 minutes 5 times a week. This is a demonstration of the pursed lip breathing and diaphragmatic breathing. A very important part, the bronchial hygiene techniques, which involve the postural drainage. These shows the various positions of postural drainage when various different segments of the lung is affected. Chest percussion, which loosens the mucus through the rhythmic clapping. And this shows the active cycle of breathing technique, which is a part of both bronchial hygiene as well as the breathing retraining. Oscillatory PEP is a very novel treatment device, which when the patient exhales through this device, it produces a rhythmic vibration in the airway of the patient, which helps in loosening the mucus and helps in clearing the secretions from the airway, which can prevent dyspnea. NIV, it has already been discussed by my previous speaker. However, one point is that proportional assist ventilation during exercise training can enable a higher training intensity, leading to a greater maximal exercise capacity, and the addition of nocturnal domiciliary NPPV in patients under pulmonary rehab programs have shown to increase the exercise tolerance and improvement in the quality of life. Lower extremity exercises like walking, treadmill training, bicycling, stair climbing, and upper extremity exercises with ergometers, unsupported arm lifting and resistive exercises are very important for PR. Additional exercises like Nordic walking, non-linear periodized exercises, swimming and Tai Chi may also be prescribed to the patients. Other considerations during exercise training are the optimal bronchodilator therapy, which is to be given prior to the exercise training to enhance the performance. Patients on long-term oxygen therapy should continue it during exercise training, but may need to increase the flow rates during exercise. Oxygen supplementation during pulmonary rehab, regardless of whether or not desaturation occurs during exercise, it allows for a higher training intensity and reduced symptoms. So what are the benefits? It increases the fat-free mass or the lean body mass. It normalizes the proportion of the type 1 fibers. It increases the cross-sectional area of the muscle fibers. It increases the capillary contacts to the muscle fibers. It increases the capacity of the oxidative enzymes. It increases the glutathione levels and normalizes the decline in the intracellular pH and the increase in the lactate levels. Neuromuscular electrical stimulation, especially in the severely disabled COPD patients, 6 weeks of NMES shows improved muscle strength, endurance and whole body exercise tolerance, breathlessness. Psychological support, as I've already mentioned, is very important, and if required, cognitive behavioral therapy should also be offered to the patients. Nutritional support, a very important and overlooked part. The patient should have a low carbohydrate diet which is supplemented with essential amino acids to increase the body weight and the fat-free mass, especially in the weight losing and frail patients. The protein intake should be 1.2 to 1.5 grams per kg body weight, and PUFAs, polyunsaturated fatty acids, should be supplemented in the diet. There are some pharmacological interventions to increase the muscle mass, like anabolic steroids like nandrolone decanoate, 50 mg for males, 25 mg or for females, 2 weekly, 4 doses, or recombinant human growth hormone 0.05 milligrams per kg for 3 weeks, in addition to 35 kilocalories per kg and 1 gram per kg protein intake. This increase the fat-free mass. However, important point is that these pharmacological interventions only increase the muscle mass, not the muscle strength. Strength training programs are still necessary in spite of these pharmacological interventions. Outcome assessment, I'll sum up soon. Providing the patients with an opportunity to give a feedback is an useful measure of quality control. It allows the coordinators to identify the components of the pulmonary rehab which patients find most useful, and it allows tailoring of the rehab program to change the needs of the patients and the caregivers. These are the primary outcome measures which are most commonly used: Boggs scale, COPD assessment test, respiratory disease questionnaire and St. George's questionnaire. These are the secondary outcome measures: the shuttle walk test and the 6-minute walk distance. Benefits I've already discussed: the improved exercise capacity, reduction of dyspnea, improved quality of life, decrease in anxiety and depression, reduced healthcare utilization, and increased independence. The challenges and future directions is the most important challenges are the limited access and referral to pulmonary rehab programs, low patient adherence, need for increased coverage through tele-rehab and home-based models, integration with the digital monitoring tools, AI is there to help, and greater focus on the long-term maintenance strategies. So our take-home message is, pulmonary rehab is a cornerstone of COPD management. It involves physical, psychological, and educational interventions. It requires a coordinated multidisciplinary approach, and it leads to improved patient outcomes and reduced healthcare burden. Thank you.
Thank you, Dr. Mukherjee, for your presentation. Now the house is open for question. You can take 1 or 2 questions only.
May I ask one question?
Yes.
In a patient with the 65% burn patient, including the chest, so how you will give the chest physiotherapy of this patient?
Sir, in case of the burn patient, if the patient definitely has bandaging in the chest region, so in this case, to prevent decline in the lung function of the patient, what we can do is we have to focus on the mobility of the upper limbs, because we cannot per se provide chest percussion as such. If possible, if the patient can tolerate, we cannot give the manual chest percussion with the hands. We may use a chest vibrator, but still the most important part is to maintain the mobility. Chest vibrator, yes sir. We can use the upper limbs. The mobility of the upper limb should be maintained. Strength training of the upper limb should be maintained, because these in turn activate the accessory muscles, help in the movement of the accessory muscles of respiration, which can prevent a decline in the pulmonary function.
Thank you, Dr. Mukherjee.
Thank you, sir.
Now we just conclude the session.